Welcome back, guys. Again, this is Dr. Severin. Like I mentioned, the next couple of units will get into more organ-specific care and outcomes for both heart and lung transplantation. So, cardiac transplantation, heart transplantation, the very first successful heart transplant in a human was done by Christian Barnard from the Groote Schuur Hospital in Cape Town, South Africa. He performed this procedure on a patient by the name of Louis Washansky, who is a 54-year-old grocer with irretractable diabetes and heart disease. So the procedure was a success. However, the patient died within 18 days after the transplantation due to pneumonia. And we'll talk about in the next slide that human-human transplants, right? The first one again was done in '67. It really didn't start coming onto the scene until we started having these cyclosporin-based immunosuppressive agents, those calcineurin inhibitors. So here's a picture of Dr. Barnard and then him performing the surgery as well back in '67. So we've really evolved since that point. So like I mentioned, the first one was done in the '60s, but the procedure really didn't start coming on board to like what we know it is now until the '80s because the outcomes weren't super great until we had those calcineurin or cyclosporin-based immunosuppressant agents, which are calcineurin inhibitors. So 3,400 of these are done annually in the United States. Again, we talked about, there are a lot of patients who could use one, and unfortunately just are not hard to go around. We, have a special, I have to always acknowledge this when we talk about heart transplantation or cardiac transplantation, is LVADs. So we talked about this in the cardiac unit, about how these originally, the very first LVAD devices were larger in size. They were used really for that patient, who was kind of on their deathbed, like needed a transplantation. The LVAD was there to kind of keep them stabilized and keep them in the hospital until they could get that organ. The outcomes weren't very great. The patients couldn't move around that much. They're pretty bulky. And now we've got these devices that, are more mobile. So our second generation devices, our third generation devices that patients can get around and even go home and exercise. So for many years, LVADs were viewed as a bridge to a transplant. So they would be put on an LVAD again just to keep them alive long enough that they can get a transplant. They would be institutionalized. Admitted to the hospital. They would not be discharged home. They'd be in the hospital, hooked up to this device, kind of stuck in their room, or maybe even in the bed. And now with these smaller devices, it can be even destination therapy. So some patients just may elect that I'm going to just try to live with my LVAD because I can do most things and I don't want to go through another procedure. And then I have to deal with all the other, like we mentioned in the first unit, all the other potential issues that arise from an organ transplant, right? All the medications, the cancer issues, other things. So it's a conversation that is happening more and more often, especially as these devices get better. And we'll talk about some unique things that are kind of on the frontiers of medicine right now and in human physiology. So again, just looking at the adult, the recipient age and the donor age. This is not something I'm expecting you guys to kind of remember, but just looking at the percentage of the hearts that are given, we try to make sure that hearts are always matched by size to the person. And as we'll see here, I think this graph plots it the best that generally the people getting transplants, if you just look by sheer numbers, are people like over 40-ish years old, right? We don't give as many in elderly populations. We don't give as many aren't as many in younger populations, pediatrics or young adults. But if they have a genetic or acquired cause, it's a different story. And while you might think we try to give older people the same aged heart, you can make that kind of assumption by looking at this, right? Like, well, if we plot 55 to 55, they fall here. But if you look as well, like even someone who's 55, like they may get a heart from someone who's a little bit younger. So the connection between age of recipient and the age of the donor is not a one-to-one at all. but it just illustrates or elucidates that we do for sure. The primary number of patients who get this are older populations, and that makes sense looking at heart failure around the world and how that particularly affects older individuals. Right. So looking at mechanical circulatory supports, you may see these referred to as MCSDs, and I'll try to write this out on our little guy here. Where is this? There we are. MCSDs, right? Mechanical circulatory support. So that's your LVAD, your ECMO, total artificial heart, RVADs, VAD plus ECMO, LVAD plus RVAD, or BiVAD, and total artificial hearts, ECMO, or extracorporeal membrane oxygenation. So as I mentioned, the early models of LVADs, like patients weren't really moving around too much. They were really just viewed as a bridge to transplant, and the devices weren't as refined as they are now. So if you look at 2005, LVADs alone, for the number of individuals who are bridged, right? These are patients who are going to get this transplant. 15% of them were on roughly, or just under 20% were on LVADs. If you look at data now in 2016, published in 2018, we're looking at rates close to 50% just from LVADs, right? So it's a large percentage, and again, that has to do with the technologies and improving. We also have more sites as well, but the overall number of patients on these LVADs goes up because the technology is better for sure. Now, if you're looking for great information, I would really recommend checking out ISHLT, their International Society for Heart and Lung Transplantation. This is where these slides have come from. They publish these publicly, open access for anyone to have. They also provide the annual statistics, and this is global data. This is not specifically from the United States, but it gives us good trends overall. So, and they are the reference standard for any information coming out about heart and lung transplantation. Fantastic organization, and I'm really, really proud of their commitment to the open access of science. So they're a great organization to follow. I think they got a Twitter account too. All right, so this looks at the number of combined transplantations. So, we're doing multiple different organs. So it's kind of neat, right, that we're getting so subspecialized and just like more advanced in a procedure. So looking at heart, kidney, which is kind of the top one that you're seeing done, which would make sense. Not kind of common that patients often with significant kidney issues may have significant heart issues and vice versa. So if you looked at 1994, right, we were doing 25 combined heart-kidney procedures, right? And if you plot that to 2016, this was published again in 2018, that's up to 150. So we're doing a lot more of these, right? So it's just super impressive how many of these, of the total transplants, right? We're looking at these multiple or combination of multiple procedures. Now, part of what happens as well and why we see more transplants done and even more combined organ transplants is, again, the real kind of use of this came about in the 80s with these new medications. It's still an evolving treatment. It's only been around for a few decades, and you need a specialized team of surgeons, providers, and other healthcare workers, social workers, right? It's a very subspecialized area of medicine. It's also a hard area to research as well because patients' care is going to be very individualized. And just some facilities just don't have the abilities to provide a heart and lung transplant. So not every hospital or healthcare system does this. But the more that are, the more people that are trained, you'd expect these numbers to continue to increase because we have even greater subspecialized and trained clinicians. So just a breakdown again of the percentage of individuals who losing my train of thought, the causes for their heart transplant or like why they got transplanted. So if we look at North America, we look at non-ischemic cardiomyopathy or NICM. being one of the leading causes, and the second one being really ischemic cardiomyopathy, so 35%. So again, looking at different causes. Retransplant, which we'll spend a little bit of time talking about as well, like 3%. So some people do get another organ. If we look at Europe, a little bit different. So, again, our heart disease burden a little bit higher in North America. And then around the world, looking around the world, we see different causes. But again, two biggest ones would be, again, non-ischemic cardiomyopathy and then ischemic cardiomyopathy. And in America, we see a little bit more here. Looking at the age of diagnosis, like I mentioned, it's not just, older people who get it, but if we look at the types of conditions, right, we typically see, and it's probably what shifts these percentages a little bit to favoring non-ischemic causes. If we look at younger people, it's generally non-ischemic, right? It would make sense, like you're probably not going to develop heart disease and then ischemic cardiomyopathy, at that young age. It's usually going to be some kind of acquired or genetic condition, right? Some sort of cardiomyopathy that's not ischemic related. But as we get older, right, if we're in our 60s, right, it's going to be a large portion of it, right? A lot more of it's going to be ischemic, and that makes sense given the lifestyle problems that we're seeing in older populations, especially when you get above 70%. So related kind of ischemic heart disease, and then if we look at the percentage of retransplantations, I find this kind of interesting as well. Like I mentioned, we're getting better and better at at treating these conditions and managing these conditions, and we're doing more and more of them. And again, it's really started in the 80s. But if we look at the number of retransplants, so these are people who had a heart transplant that got another one, which is just amazing that we're able to provide that for some people. We've kept the overall percentage fairly stable, hovering around 3%, but the overall number has gone up as well as the total number. That's why the value, the absolute percentage has stayed relatively stable, despite the fact that the absolute numbers have kind of skyrocketed over the past 20 years or 30 years. So again, still a small percentage, like we're at most looking at 5% of all total transplants, but we're doing about 100 or so per year of patients who had a heart transplant and got another one. And these were in adults, not in kids. And then looking at, again, just characteristics, generally we're working with patients who are at not super obese. They may be a little overweight. We're not going to transplant a heart in someone who, again, is morbidly obese, has out of control risk factors, because that heart's just not going to be successful, right? And then who are we getting the donor age, right? So again, the recipient age, we said we're typically seeing in older people, but like people as young as 24, 25 for the adult population, are getting these transplants. And if we look at the and this is global numbers, right? Again, United States, it's 3,400, so this is around the world, and this is over many years. So again, the donor age, right? Typically, a little bit younger, but not always. The difference is usually about 17 or 16 years or so, right? So typically seeing it given to older populations, but the hearts typically come from younger populations. And we want the donors to be healthy, but we also want the recipients to be as healthy as possible as well. So we're going to make sure that their BMI, again, on the average 26, no more than about 35. So again, just looking at the percentage breakdowns. Again, this is just a chart of all the things that we're seeing, but this is the donor and receipt characteristics. So again, mentioning that non-ischemic and ischemic are the top two reasons why people get a transplant. My little guy, where's my little pen? Looking at it here. And then donor cause of death, usually a head trauma, or they had a stroke of some kind, or maybe another cause, potentially like an accident or something of that nature. And then again, looking at what they're on prior, typically they're hospitalized at the time of transplant. They're on some sort of microcirculatory support. Usually it's going to be an LVAD, and then maybe on IV inotropes, like we've mentioned, dobutamine, right? Different things that kind of keep the heart pumping as hard as possible. So the indications for a heart transplant is, again, cardiogenic shock requiring continuous inotropic support, like we need to keep that heart pumping, or mechanical support. Persistent NYHA class 4 symptoms that just don't get better treatment, intractable angina, life-threatening arrhythmias, like the heart that keeps going into VFib, different arrhythmias that just can't stay stable. Or they're on they have a congenital heart disease with 3 or 4 symptoms. They're, again, refractory to treatment. Patients will often be given an exercise test, whether it's an injection, so they can sometimes give a patient, an injection to see how the heart responds, like a drug-induced stress test, or we can give them, put them on a treadmill and see what's their peak exercise capacity. And people, under a 12, milliliters per kg, or less than 50% of the age predicted VO2 max will be, indicated for a transplant. So exercise testing has a lot of value and beyond just like fitness assessments. It's often used in diagnostics to determine if someone is eligible for a cardiac transplantation. Are they sick enough that they need a cardiac transplantation? There are some arguments as well that, is there a cutoff for when someone's too unfit and needs wouldn't be a candidate. So that's an argument as well too. Like we have the threshold for when someone's sick enough, but is there a threshold for someone being too sick potentially as well too? And we'll get into that in the rehab outcomes in a bit. So again, indications, again, the heart failure survival score, I'm not going to get into that, but we typically group patients based on their likelihood of dying. So are they at is their likelihood of surviving with heart failure high, low or medium? So is their risk score low, right? Is the risk score medium, or they have a high risk of dying from heart failure? So patients in a high risk or medium risk, are likely to need an urgent transplant, or they're going to die within 1 year, right? And then we also had the Seattle Heart Failure Guidelines, which looks at similar things, and again looks at individuals with less than 80% chance of living to 1 year. So again, it's all based on kind of medical urgency. Like, do you need a transplant, right? Like, is that something that we need to get? Are they going to live beyond this year? Because again, we don't have enough organs to transplant to everybody who needs one. So we got to prioritize, right? Who is not going to survive if they don't get a transplant, and are they a good candidate? Some contraindications, right? So absolute, and this may be vary depending on the facility, but if someone's got irreversible pulmonary vascular resistance, like if they have really high pulmonary hypertension, that's again going to load the left ventricle or the right ventricle, potentially leading to right heart failure, and that can lead to that organ failing, right? If we're going to give someone an organ, we want to make sure that it's going to be successful. Do they have active cancer? Right? Because we're going to immunosuppress them. We can make that worse, right? As well as just, are they going to survive the transplant if they have cancer? Do they have an active infection? This can be the most heartbreaking thing, because working in transplant, we try to keep patients, protected as much as they can, but they get infected, and even if they're a status 1 patient, they're no longer eligible, because we're not going to do an operation on someone with an active, influenza infection or bacterial infection. So it's really important that patients, even prior to infection, take significant measures for vector control, because if they get infected, they are bumped off the list until that infection clears. And I've had patients that were we knew of a heart that was probably going to be ready for them, or a lung, and they got sick. And that heart or lung ended up going to somebody else. So it's a very, very serious thing. Vector control, I don't think people realize the ramifications of it across healthcare. If they have HIV or an AIDS, again, we're going to already be suppressing your immune system. Again, are they going to survive? And the severe cerebrovascular disease, just because, again, are they going to survive the trauma of the surgery? Because they're going to be in a bypass a little bit longer than other procedures. And we know what happens to cerebral blood flow during surgery. And then again, the risk of having a stroke after the surgery. Relative contraindications, these are patients that, this may be considered, again, obesity. We want their BMI to be below 35. Again, this could be, maybe extended, point one here or there, depending on the facility. But again, are they going to survive the procedure? We don't want to put this in a patient who's BMI of 50. There's, that's just the likelihood of them surviving, especially with a lot of fat mass, is just not super high. Again, like when in a state of obesity, it makes the heart work harder. So they have typically very high cardiac outputs at rest because the heart's beating a mile a minute to perfuse that larger body. Put in a very obese patient, that heart's just not given an opportunity for success. Their age. Now, this has changed, and it's maybe facility dependent. It used to be around 65. We'll talk about one of the reasons why that changed. But again, are they going to survive the transplantation? And you're seeing that creep up even a little bit above 70 in some places, right? And renal dysfunction, poorly controlled diabetes. We talked about that as well. We want their, one as well because their blood glucose is probably going to be higher after transplantation. We want to make sure they have well-controlled blood glucose. And then unreliable caregivers or social support. Again, like typically with a transplant, they're going to make sure that you have a caregiver prior to transplant is always with you. So if you get the call for your organ, you can be called in to the hospital in a moment's notice to get the transplant done, right? Especially if you're going to be home based, right? And we need to know that you have someone with you 24/7 after a transplant that's going to help you stay compliant, right, with medications. So not only does a patient need to be compliant with their medications, their caregiver needs to be compliant with medications. And again, like the setting where I had worked in when working in heart and lung transplantation, the VA setting, and there's a large number of patients there that don't have a spouse. So that can be a bit of a stressful situation if it's not your partner, but maybe like a kid or a friend. It can create some unique social issues. So that's the social worker is usually involved here to make sure that caregiver support is needed, or as well as psychosocial impairment that jeopardizes your ability to again manage this effectively. Because again, the goal of a transplant, you're giving the organ to this patient. It's going to have a high likelihood of that organ being successful because there are thousands of people that could benefit from this organ, and we're choosing this one person. One of the reasons why the age restrictions have changed is this guy here, or it's been postulated. So Dick Cheney, I'm not sure if you guys remember this, one of the vice presidents of the United States under Bush. He, at his time of heart transplant, which was in March 2012. He had 5 heart attacks. He had I think he had multiple surgeries, CABG, PCI, angioplasty. He had his first heart attack in 37, and he eventually got an LVAD in 2010 at the age of 69. And the device kept him alive long enough. He got transplanted at 71. And again, at that time, there were thoughts like, well, we really should be reserving this for people under the age of 65. Like, are they going to survive the transplant? Obviously, Dick Cheney's a little bit different person than most people. And he was able to get a transplant. So that changed the conversation about who is, who's kind of eligible due to age for cardiac transplantation. So again, these things are always kind of in evolution and in flux as more evidence is produced. So in the next video, we'll get into the donor allocation system and how do we go about choosing who gets a heart.